A female patient aged 56 presents with an abscess in the left mandibular first molar. The situation evolved over 14 months, with various attempts to treat with antibiotics. It is obvious that this type of lesion cannot be cured using antibiotics, which is a customary practice of our professionals, although it is not the best. It will not be cured using antibiotics. The cause lies elsewhere and has multiple facets. It is the cause that needs to be addressed, then the effects will disappear. A clinical image with a probe inserted almost 11 millimeters. We usually use a CP11, which best indicates the most coronal part, which is 11 millimeters, and the probe indicates its condition with precision. The X-ray image shows us the severity of the lesion. I believe it is extremely obvious which type of lesion destroyed the bone that caused the lesion. It is of endodontic origin. The periodontium in the neighboring teeth was seen clinically as well as via X-ray. Here we can see perfectly that it is intact. The lesion is apical, extending almost 10 millimeters from the apex of this root to the end of the lesion. And, even when we cut the X-ray, in the clinical image we can observe how this instrument, which raises the periosteum, penetrates into the lesion almost 10 millimeters. So, this allows us to assess the severity of the lesion. What will happen if we do nothing? The aim is to explain this to the patient. You've got this is what caused it, this or that treatment is proposed, this could be done or nothing could be done, and if nothing is done, these are the consequences. It is our obligation as health professionals to explain all these details to each patient. It is also our legal obligation to do so with the patient when they don't sign the informed consent form. In this case, tricalcium phosphate cones from Septodont were also used. But in this case, we only see the lesion because cones cover almost up to the most coronal part in order to cover the contents of this lesion. Here, we see healing a few months later. And more than an X-ray at this time, 10 months after the extraction and insertion of the material, you can see the amount of new bone in the extraction site. I think this clinical image gives us an idea of the results that we can observe when using this material. I insist, with a correct diagnosis and knowing exactly what we are going to do and what we can expect from the material. This photo is the opening just before insertion. Let's see what follows. Sorry, before going any further, here's an image from the 17th of September of last year. We can see that the material was still present and the density with which the material has been replaced by the patient's bone. How do we know it's the patient's bone? Very simply, when we proceeded with the trephination of the opening to insert the implant, although this is subjective, on preparing the site to position the implant, we met with a hardness that was hardly any different from that which we can encounter in healed bone. I stress that this is a clinical judgment, but the implant meets the most basic requirement for inserting implants, which is primary stability, the physical stability that gets this implant started. Occlusal view. Observe here the amount of tissue that we have in the area where there was only 1 millimeter of active bone and a lesion that had practically taken over the entire vestibular plate of the root. For this, the most important thing, and this is probably critical, is the date. September. A while ago I said 2016. Sorry, I made a mistake. Let's confirm. Here, this X-ray was taken in September 2015. The implant placed in this site where the patient's bone replaced the material. The implant is completely functional 16 months after the prosthetic restoration. We have this X-ray taken on the 25th of May 2017, completely functional. Let's clarify something that is critical. The patient has excellent personal control of plaque and impeccable hygiene habits. And I think that we all know that whatever we do, whatever periodontal or prosthetic procedure or other implants we carry out, if the patient does not adequately control plaque, we increase the risk of failure, and perhaps most importantly, if the patient loses teeth, which is not the case here, but if the patient loses teeth due to periodontal disease, the literature reports that there is the same risk of losing implants as when they are lost due to periodontal disease. This is why I want to clarify that the patient has good control of plaque and makes periodic visits to my surgery.